So, Mohamed, can you hear us from Rio?
Yes, I can hear you quite well. I hope you can hear us and see us.
Yes, very well.
So,
very well.
Greetings from Leipzig. It's in the afternoon now, as you know, so good morning to Rio. And thank you for having us with you this year. I'd first like to introduce my team. You can see we're a lot of persons here. We don't have this luxury when you don't have a live case.
Yes.
But
let me just
to the fact that we can, yeah.
We have a panel of experts here that will certainly help us to conduct this educational cases that I'm sure you have to show us. I know you have two cases, one coronary, one TAVR. We have here Daniel Chamié, Rafael Cavalcante, Oli de Baker, Professor Prendergast, Filippe Filippini, you know, from Argentina, Oscar Mendiz, and we still have Eduardo Pessoa and other very experienced panelists that will help us here, okay? So thank you again for being with us. It's a great pleasure, and you're always doing great cases from Leipzig for us.
Yeah, thank you, my friend. So my team, as you can see here today, on my right-hand side is Stefan Desch, who's an interventional cardiologist. We have Khalil Jawad, who's a cardiac surgeon. We always have a cardiac surgeon, as you know, here in Leipzig, doing the procedures with us. And we have Max Maineri, who's the anesthesiologist, taking care of the patient who is awake, as usual. And we have otherwise a big team. We have Annette, we have Nadia, we have Lisa, all taking care of different stuff here. So let's start by introducing the TAVR case. Next slide, please. So this is a typical TAVI patient, actually. So no big surprises, an 85 years old female. She's symptomatic. As you can see here, she's a bit overweight and small. And she has some comorbidities, including diabetes, hypertension, dyslipidemia. Importantly, she also has chronic corticosteroid and MTX therapy because of arthritis, and she has what we call Bound's disease, which is a cutaneous squamous cell carcinoma in situ. Next slide, please. On echo, you can see here she has actually a typical paradoxical low flow, low gradient TS, which is severe. A mean grade of only 24, but a valve area of 0.6, and stroke volume index that is well beyond the cutoff of 35, so it's 27. And otherwise some mild disease of the other valves and no significant pulmonary hypertension. Next slide, please. You can see here, this is her CT, and maybe this is a point that we can discuss how you guys are doing this. We usually do the CT, we actually do the CT in the majority of our cases before we even do a coronary angiogram. And you don't need to modify a lot in your protocol to have a very good assessment of the coronary arteries. You can see here that you can actually exclude significant disease with quite certainty in the RC and LCX. The LED has some moderate disease in its proximal segment. There was a bit of discussion in the heart team whether we should do a cath because of this, but we said we will not because she also has chronic renal insufficiency. Her GFR is around 21. So we thought this is enough and the patient doesn't have angina, but we can discuss this as well. Next slide, please. This is her aortic valve and root anatomy. Not a lot of calcification. A small anatomy. So you can see here the area is less than 350, a perimeter of 67. So the annulus is somewhere between 20 and 21, good distance to the coronaries. more or less good access with a little bit of a tortuous aorta, but no big problems that we might anticipate. You can see here that the right brachiocephalic trunk is a bit tortuous. This is one of the things when we were thinking and planning the procedure, whether we should use embolic protection or not. To tell you the truth, we don't use it routinely, but we were thinking of it in this case. But we said that we were not going to use it for different reasons. Interestingly, our secondary axis here is the right radial, and we tried to pass and it was okay. So probably it would have been anatomically suitable for embolic protection as well, but we opted for many reasons not to use it. So this is the last slide. So the procedure is being done under local anesthesia. The percutaneous access is through the right common femoral, as said. The contralateral axis is the right radial. We are planning to predilate with a small balloon. The patient has been included in the so-called PROVE registry, which is a big European registry aiming to include 2,000 patients treated with the accurate valve. This patient has been included in the registry. We have chosen the accurate here for several reasons that we can discuss. We aim at implanting the valve commissurally aligned, and we are integrating the cusp overlap view for some reasons we're going to demonstrate. Again, we were thinking about doing the coronary angiogram or not, and we decided together, Stefan, that we are not going to do it unless you want us urgently to perform it. Then we can even do it after the TAVR if you think this is necessary. So this is the plan, more or less a straightforward transfemoral TAVR procedure. Let's hope that it remains like that.
So looks like a very good candidate for TAVR.
Yeah.
Yeah, looks like a very good candidate for TAVR. Let's see if our panelists have any comment.
Yes, I think so. I mean, I don't recall now the age of the patient. What was the age?
85.
85, yeah,
85.
sure. So, yeah, sure. I mean, 85, the small anatomy is another argument. Even if this patient would be younger, it's a relatively small anatomy, aortic annulus. So definitely a good TAVI candidate, transfemoral TAVI candidate, and they do it state of the art. I think also with no general anesthesia needed here. And I think indeed for this particular anatomy, since the perimeter was 67, I think accurate is an excellent choice here, because you want to get you want to avoid a patient prosthesis mismatch. That's something you want to avoid, of course. There's relatively mild calcification, so also for that indication, it's typically a good choice, I would say. Yeah.
Yeah, we see that the leaflets are thickened more than calcified, right, Mohamed? Still needing predilation in this situation?
Good question. Maybe not, but our practice is to predilate every accurate case. So I wouldn't skip it in her case. Sometimes even these less calcified leaflets, when they are very thick and fibrosed, they still maybe need some preparation before valve implantation. And we're going to take a small balloon, so I don't think we will have a big problem with predilating. So we decided to keep our standard and predilate.
And Mohamed, can you comment a bit on?
You can see here we already,
No, can you comment a bit on your strategy
so
for pacing and the pacing and your pigtail? So I see you keep a pacemaker from the groin and you go from the radial for the pigtail. That's your standard approach, or?
Yes, so still we are a little bit old school regarding pacing, a bit of dinosaurs, if you want to consider it like that. So we still put a pacemaker in the majority of patients. We skip it sometimes if the patient, of course, has a pacemaker or in some other circumstances, but it's still part of our routine practice. You can discuss the pros and cons. But we also, I mean, these patients, they don't have a central line in our practice. So the venous sheath is for us also a way to have venous access in case we need it. And we also still place a safety wire through the venous access just in case something happens and we need to go rapidly on support, then we don't lose time. So this is part of our historic strategy for TAVR patients, and we didn't really change this.
One small
the right radial artery.
Mohamed, one additional
Yes.
question maybe that where the audience would be interested in, because we had in a couple of previous sessions some discussion, 1 proglide, 2 proglides. I saw this patient had some obesity, BMI of almost 35. What was your strategy here for the access also?
Yeah, good point. We take actually 1 proglide for almost all patients. And I took also 1 proglide in her case. I don't put the second proglide up front, but of course, if we needed it, we can place it afterwards. But we don't change the strategy according to patient habitus or something like that. So I think we almost always take 1 proglide.
Yeah, we used to have 2 proglides until a few years ago, and we really didn't see any change in clinical outcome when going down to 1 proglide. So if you don't do it, I urge you to give it a try. It's really been successful with our practice.
Okay, hemodynamics, maybe you can see, maybe we can show hemodynamics for a while. It confirms what we know. So the peak-to-peak gradient is around 30, corresponding to a mean gradient of 25. So corresponds almost 1-to-1 to what we know from echo. If you like to discuss embolic protection, I think this is also interesting. While we are placing a safari wire and preparing to predilate.
Maybe Mohamed, can you comment on then your choice of is this going to be a safari, small, extra small? You have some standard choice there for, this is an accurate small, it's maybe a smaller lady, smaller cavity, or you always, what is your rationale there to use one or the other wire?
So usually I take the small, like in her case. The extra small, I was thinking while you were asking whether I should switch, because I was feeling that the small is pushing my pigtail a little bit out. Let's see how this develops in the ventricle. If it doesn't look nice, then we may change to an XS. But I thought that probably the small will be okay. It doesn't develop nicely, actually. So maybe you want to.
It is indeed a case where you could probably go for an extra small safari. You can see it doesn't really sit so well. It's gotten a little better now. I think this is okay.
I think it looks okay now. What do you think, Ola?
No, I agree. I think it looks okay. It's just important, indeed. It's a good point that the curve doesn't sit upside down, and your curve sits nicely, especially if you do accurate. I think it's really important that the curve is not going from top to down. The curve is still going from down to upwards, so that's good. And that's important just for the audience here. Yeah, go ahead, Mohamed.
The wire is now sitting on the outer curve of the ascending aorta, which is also very important. Yeah.
So Mohamed, can you tell us a little bit about your practice regarding to cerebral protection? Are you doing all cases? How you select patients for that? Let us know, please.
No, to be honest, we were heavy users. Like we were using embolic protection maybe 50% of our patients. We were also heavily involved in protected TAVR, so we included a lot of patients in protected TAVR. Of course, the trial was overall neutral. We see an advantage in the trial for the important secondary endpoint of major stroke, but we couldn't identify subgroups. So we didn't change our practice a lot. Maybe we reduced a bit, so it's not 50% anymore. Maybe it's like around maybe 30, 25%, or maybe even less. So we're trying to pick out patients where we think that we want to use it. For example, patients where we will extensively manipulate the valve or the leaflets. Definitely when we do leaflet modification, basilica or stuff, we're going to use embolic protection. Patients who have very nasty anatomy, heavily calcified valves, or if the aortic arch or the descending aorta are like contain a lot of mobile stuff, patients maybe with mobile masses on the valve or intracavitary. These are patients where we think they may profit from embolic protection. And we are all keen, and I heard that Bernard is sitting in the panel. we are all, of course, looking forward to the larger trial, to the the BHF Protect-TAVI trial. And hopefully it becomes positive, and then probably all of us will be forced to use it in all patients.
So thanks, Mohamed, for that link. I'll just make a few comments about the BHF Protect trial, if I may. So this is a trial which is similar in design to the Protected TAVR trial from the US. The differences are that it is an all-comers trial. It's not powered by neurological assessment of stroke. It's a clinical assessment of stroke by cardiologists and their teams. So it's a very pragmatic, everyday clinical trial, typical UK design. The number needed to enroll is 7,700. It's a big trial, sponsored by the British Heart Foundation, and we are over halfway in enrollment. So it's likely that recruitment will finish at the end of 2024, and hopefully we'll have the results available in 2025. So it's a long journey, and...
Are you planning an interim analysis of this trial?
So there was an interim analysis in Q1 of this year, and the Data Safety Monitoring Committee have approved for the trial to continue. So read into that whatever you wish, but the trial is ongoing. My only concern is that if you need over 10,000 patients in randomized trials to demonstrate benefit of a procedure, then the benefits are going to be quite small. That's my only comment at this stage, but I have no access to the results. And clearly we need clarification for our practice.
And in your practice, what are you doing now?
Well, a little bit like Mohamed, you know, we were enthusiastic by the concept for cerebral protection, and we were constrained by finance in the UK. But we enrolled very enthusiastically in the trial. 40% of patients in the UK are randomized, which is pretty impressive for a single country. In terms of our everyday practice, then a bit like Mohamed, we try and identify the risk patients. So it's bicuspid valves, patients with a lot of atheroma or calcium in the arch of the aorta below the head and neck vessels, and second-time valve-in-valve procedures. We don't do basilica. It's a very complex procedure which we don't offer routinely, but that clearly would be another theoretical consideration.
Perfect, thank you.
And let me ask you something. Do you believe that we can reach benefits with cerebral protection devices when we have probably more than 50% of the stroke during the hospitalization occur more than 6 hours after the procedure? And additionally, do you believe that this such a huge effort should be complemented with some neuro test, like, something to prevent like cognitive deterioration?
Yeah, so these are very, very important points. So, of course, the cerebral protection device only protects during the procedure. You take it out at the end of the case. So we need to be more rigorous in terms of our antithrombotic strategies. We need to be very vigilant for the presence of atrial fibrillation in particular, which is a precursor for stroke. So it's not just about the cath lab, it's about being good clinical cardiologists. And it's a controversial area, and it's an expensive device, so we need to justify our use of it.
So Mohamed, I think you're going to show us commissure alignment now, right? Another important feature of this device.
Yes, I was just waiting until you finish the discussion with Bernard. So the first thing, we introduced the delivery catheter with this flush port looking at 6 o'clock. So this is now routine practice, because this increases the likelihood that you get automatically commissure alignment without needing, without the need to torque the catheter a lot. Then we are now in the 3-cus view. And then we're going to cross. When we started doing this, we were doing this actually a little bit high up in the ascending aorta, and now we feel more comfortable doing it almost in position to avoid any changes. And we don't have a lot of hemodynamic issues doing this, but let's focus on that and see whether she needs hemodynamic support or not. It looks okay. Okay, so what we're going to look now at in this 3-cast view is, I'm going to try and get the wire out of the pigtail, and then you can maybe see a little bit better. So it's not that easy to place it in a proper way, but let's keep it here. Not sure whether it's in the non-coronary, but we'll have a look afterwards. And then let's focus first on alignment. So what we look at here are the 3 posts you see up there. I'll do a cine for you, and you can see here that they look as if they are 2 on each side of the wire in the middle, and the third one is somewhere hidden behind this wire or in front of it. This is what we call the 1-1-1 position. It could be either we are completely correct or we are completely wrong, depending where the middle post is. If it's posterior, then we're correct. If it's anterior, then we're wrong. So in order to differentiate, we'll go now to the cusp overlap view. And then in the cusp overlap view, if we are correct, remember this is RL cusp overlap, so it should be like that, then we're correct. So one post is on the right-hand side, exactly in between the right and the left cusp, in the commissure in between, and 2 are overlapping on the left-hand side. And in addition, you can also see this free strut or this free cell of the accurate platform that points exactly also to the right-hand side. So we feel that we are aligned.
Yeah, the free cell is very clear there.
Yes. Yes. What we also now do in the cusp overlap, and this is something I learned also from friends such as Ole, I'm going to check my depth here. And then I'm going to implant in 3 cusp view. But I will check my depth here. Let's do an angiogram, which looks quite nice to me. I mean, I look, of course, at the marker, but I also look at the upper crown, which are probably more important, just to make sure that the upper crowns are above the leaflets. We don't want to land too high with this device. We want to have a landing zone like below the annulus of around 5 to 7 millimeters. So it looks good here. And let's check now in the other view, whether we need to maneuver a little bit or not. It's also important that the valve hugs the outer curve. This is why I'm pushing on it a little bit. Unconscious. It doesn't look bad in this view as well. But tell me what you think. Maybe I go like maybe 1 millimeter inside, but otherwise I feel it's fine. But tell me what you think. We are in a stable position now, and we can maneuver if you think we should. You still hear me?
Yes. Could you explain why you changed from the cusp overlap view to the 3 cusp view to check the position?
For implantation? Yes.
Yeah.
Because in the other view, as you noticed, you don't see the aortic arch unfolded. So you don't really know whether the valve is hugging the outer wall or not, and this is important for this device. So with some experience, maybe you will be able to do this, but we feel that it's more clear if you go LAO, just to check finally that the valve is coaxial to the outer aortic wall. Okay, we will open now the first part of the valve. Remember, this is top-down deployment, so Stefan will open a little bit. And now it's opening from above. I'm having a bit push on the valve, just to make sure that I don't lose position.
Fully open.
Fully open. And now we were going to check again whether we're still there. Maybe we reduce contrast a little bit. Können wir auf 6 Milliliter Kontrast? We don't need a lot of contrast here. So just to spare her kidneys. Okay. Anxious. Yeah, so I think it's fine. So now Stefan will remove the safety button.
I've already done this.
Okay.
It was sitting here.
Then we usually pace at 140. Pacing bitte auf 140 an. And then this step is rapid. Stefan, du kannst.
Pacing
Stop
out.
pacing. And I think it landed in a position that we wanted. So now we'll take care just to disengage it safely. So this is something that you have to do fluoroscopically guided. Otherwise, you may get surprised that you end up pulling the valve out. And then we're going to remove the delivery catheter, check our hemodynamics, and then check our result. Regarding alignment, it looks nice here in the 3-cast view. So again, if you look at the 3 posts, they look more or less symmetrical, like 2 on each side, 1 in the middle, which signifies that probably you have achieved good commissural alignment. You can actually calculate this also with a very nice formula, but you don't need to do this in clinical practice, but it may be helpful if you want to do some research work on that topic. So there is a way also to calculate alignment fluoroscopically.
So maybe for the audience as well here, I agreed on the stage where they took the decision to release. It's always a matter here of making an assessment. How much push on the valve do you need? And I think you look, of course, to several aspects. You look to the marker, where the marker is just on top of the annulus, but you can also look to the wire, the stiff, the safari wire, how much it's bending up to the outer curvature of the aorta. So I think Mohamed had a really nice push, and pushing harder, especially in this case with mildly calcified leaflets, would be also dangerous in a way that you may push the valve into the LVOT. So I think I would have done exactly the same strategy. He had just a moderate amount of push forward on the valve. He had a good height or depth, and then went for the acute expansion of the lower part of the stent. So I think the valve sits in a good position, but let's check now for hemodynamics and for the aortic root injection. Yes.
Yeah. So hemodynamics look good. Do you see them on screen? I think you can see them. So no gradient as we expect, but also good separation between the diastolic aortic pressure and the end-diastolic LV pressure. So, of course, the recommendation, like the usual recommendation, is to do an angiogram, in this case, while the pigtail is still in the ventricle. We actually don't do this if we feel comfortable with the hemodynamics, that we are fine, and we want to have a clean angiogram, which is also important for the registry we're doing, because there are a lot of sub-studies, including some looking specifically at quantifying regurgitation using video densitometry, and for that, you don't want to have something in the ventricle. So this is why we're going to do it. If we need to recross, we will recross. There are some tips and tricks for that, but we will do it just to spare contrast again, because we don't want to repeat the angiogram if it's fine. So let's do a pullback. Kann ich ziehen?
Do you still rely on echo evaluation after the deployment of the valve, or are you doing angio and that's all?
Yeah, this is a good question. So we don't do routine echo to assess AR. We do it if we feel that we are not confident with the result. So if angiographically or hemodynamically it's questionable, then we use echo. Otherwise, we have echo available all the time just for emergencies, and what we do routinely is, of course, to exclude pericardial effusion before and after. But to assess AR, if it looks good now, then I wouldn't look with echo. So let's do an angiogram. Angio. Schuss.
Beautiful result, no PVL. Hemodynamics is very, very good, and looks like there is good commissural alignment. Then you could cannulate this left coronary artery if needed to treat that LAD, right?
What I even think is even more important than commissural alignment with this device, if you look at the what we call the upper crown of the stent frame, I think this is the part of the device that may interfere with coronary access if you place it above the coronary ostium, particularly if the sinotubular junction is narrow. So in this case, you can see that it is below the coronary ostium, and this probably would also facilitate coronary engagement afterwards. So this is something I think is even more important than commercial alignment, because with this valve, because of the fact that it has very low metal to artery ratio, access is easy through the upper part of the stent, even in cases where alignment is not perfect. So this is now the cusp overlap view. You can see here, probably we don't have a perfect alignment. Probably we may have a rotation of around 10 degrees or something, because you see that the two posts on the left-hand side are not exactly opposite each other. But I think this is very acceptable in her case.
If I can make just one comment, I think for the audience it's important to highlight that contrary to other self-expanding devices where a shallow implant has been recommended to reduce pacemaker rates with accurate, if you want to take full advantage of the radial forces of the device, you have to deploy it at the exact position as Mohamed did just here. So a shallow implant with accurate would increase the risk of a pop-out and would increase the risk of PVL. So it's very important that that a shallow implant is not used in this device.
Yeah, I totally agree.
That's
And
a very
we don't
important
see,
comment because
yeah.
you don't need a shallow implant to have low rates of pacemaker with this device.
Yeah, and data from the teams in Germany led by Kim showed that pacemaker rates are consistently low with this device regardless of the depth of implantation. So
The other key feature
Okay,
here is
so I'm removing now the sheath. You can still discuss.
Sorry, Mohamed. I was just going to ask Ole to comment on the new design features of the Neo 2, in particular relation to the reduced paravalvular leak compared with the first iteration.
Yes, so the Neo 2 has indeed an additional outer sealing skirt and a very specific one, which is in a way has the possibility to really inflate in the diastole. So in the diastolic return of the blood flow, there are some kind of bags or mini valves on the outside which can fill the gaps. And there is even a study which we are working on together with some German centers too, where we actually prove that this outer sealing skirt works the best if we implant this valve also with commissural alignment. And that has to do with the specific design of these outer sealing bags or skirts. So it definitely reduces PVL risk. And I think if you go then back to the original scope data, I think there was not only the issue of not having an outer sealing skirt. I think this was also the issue of comparing a valve with early experience versus valves with a lot of experience. And I have seen quite some angios, actually, to be honest, from the initial scope implants. And some of these implants were also just simply too high. And that's what also Rafa alluded on. This is not a valve to compromise on your depth or to go to play as an implanter on your depth, as we have seen the tendency to do with Evolut, for example, where people go to higher and higher implants. If you go for high implant, that's actually a predictive factor for PVL. So we do not recommend to implant this high. You should really recommend it at the nominal depth of 5 to 7 millimeters.
Another important point that hasn't been very well publicized is the fact that at 3-year follow-up in Scope 1, the performance of the valves was equivalent to the balloon expandable versus the Neo 1. So although it got a bad press on the results of the early follow-up, the durability data are actually very encouraging. But we should go back to Mohamed with this nice closure.
Tell us your strategy to close this.
Yes, this is actually, so we closed with one ProGlide. And this is actually a trick that I learned from Ole. I mean, if you're using the radial artery in order to do the angiogram, you have to go down, and sometimes with the tortuous vessels, it's a bit cumbersome. So what we do in these cases, and what we did in this case as well, we just closed with one ProGlide, and then estimated that maybe the residual bleeding is somewhere between 6 and 8 French. So we put an 8 French sheath, and then did the angiogram through the sheath, and you can see here that there's no bleeding at all. So the 8 French sheath was sealing. And this is why we just took an 8 French angioseal afterwards, and that's it. And it looks actually nice.
Doesn't bleed at all.
So you leave a sheet after closing the ProGlide?
Exactly. So we remove the big sheath, we leave the wire, we close the proglide, and then we look and see how it's a subjective estimation of residual bleeding. I mean, if you see, of course, that the proglide didn't do anything, then you can do this. But usually we can estimate it's mild residual bleeding or moderate, and we've seen that if you do this and you just advance a small sheath, 6 or 8 French, you can demonstrate with an angiogram whether it's completely sealing or not. That it's like it saves you a lot of time, and then you don't have to come from above. And you can see here that with an 8 French sheath, you don't have any ooze. So we just use the 8 French angioseal, and that's it. But again, this is all is trademark, so you may want to comment on that in a way better than I did.
No, I'm super happy to see you also use this successfully, Mohamed. It's great. I just 2 additional words on it. I think what is an additional advantage above what Mohamed already mentioned, you save a lot of time and also radiation. You don't have to go from radial down. That's sometimes cumbersome, or go contralateral. I see a lot of people using their sometimes 2 minutes of fluoroscopy to finally get there. So, but that's all not needed anymore. 2 other small additional benefits, I think, is first, when you push down on the proglide, and especially in an obese patient, it's not always easy to know whether you are in contact with the artery or not. And especially with the less experienced operators, I think sometimes they tend to push that hard that sometimes they really push, and you have the risk that you can push through the artery. So when you introduce a 6 or an 8 French sheet, you actually can feel this sheet. So you have some better tactile feedback that you know, okay, I'm actually at my sheet. That's one additional benefit. Another additional benefit is that it gives you a cascade of safety nets. So I think I fully agree. I go nowadays also with 1 proglide. Some people have some fear, like, yeah, but is this safe enough? I think you can take that fear away by doing this strategy, because let's say you see now some moderate ooze. I would say if you see only a mild extravasation, it's enough with just an angioseal for sure. But if there's a moderate extravasation, a moderate ooze still you see, on this particular moment, you just take out the 6 or 8 French sheet, and you can deploy the second proglide at this stage. So then you build in some centrical down cascade of safety nets, which is really gives you a good feeling as an operator. You're always in control of the situation. Yeah. So great. I mean, I would say it's a great case, Mohamed and team there. It's I wouldn't have done it any better or any different. It's really excellent. Okay. You have a perfect valve implant, no PVL, with almost perfect near commissural alignment. You have an excellent closure here. I think the case didn't take in total just half an hour or so, and we prolonged it because of our discussions even. Yeah. So I don't know if there's other questions still from the panelists or.
Yeah, great
so
demonstration.
So you can still discuss with Stefan, and in the meantime, I will change labs and join my colleague Dimitri Zolimov for the coronary case. Okay?
Perfect.
If I may,
yeah,
we have a question.
Filippe has a question, but you can move on to the other cath lab if you wish.
Maybe if I can ask the panelists about, we have a question from Dr. Bruno. If we use single access with accurate platform, puncturing the eye sleeves to put a pigtail through it, it's used in some cases. How often would you use it?
Yeah, you can do this indeed. So there are different techniques if you really want to do. I don't do this, but you can indeed. So when you have introduced the accurate through the eye sleeve, the shaft of the delivery system is that thin. The profile is that small that there is indeed space for a parallel pigtail through the eye sleeve. So you can do that. and that saves you that you don't need a radial or another access for the pigtail. Another technique that somebody uses, Kim in Bad Nauheim, he does not introduce there a pigtail, but he introduces there just a J-wire. So he puts just a J-wire in the non-coronary cusp, and that's enough for him to do successful, accurate implants. So it is indeed possible, but I think you have to look to what's the best, most comfortable situation for yourself. If you feel confident enough with this strategy or not. I personally rely more still on my radial pigtail, but it's possible. Yeah, sure.
Thanks. We have some comment from here, probably. No, it's okay.
So maybe a comment on the data, the upcoming data for this device. As you may know, this device is being studied in a large randomized trial in the US with 1,500 patients randomized to accurate or whatever other valve is available in the US market. This trial has finished enrollment in April, and we expect results in early next year. And that is the trial that is going to be used for FDA approval of this device in the US market. And then we are also studying the next generation, which is called the Accurate Prime valve, that has minor changes in the stent design that gives the valve a little bit more radial force, and also adds the extra large size to be able to be implanted in sizes up to 29 millimeters in diameter. So this is the data that is upcoming. And then the PROVE registry that Mohamed mentioned that this patient was included in is a 2,000 patient registry in Europe, multi-center, mostly in Germany, but in other countries in Europe as well. And we will have data also on indications that are currently off-label, like bicuspids, valve-in-valves, etc.
How many patients in the US trial?
1,500 patients.
How many of you deploy this valve on 3-cusp view, and how many on the cusp overlap view?
Well, that's a good question, and there's actually just something published. We collected some data from some large accurate implanting sites in Europe, and we compared this. Of course, it's there's some selection bias, I guess, because there's some preference of the sites in what they do, but we compared it, and the baseline, there's no difference. So I think the only message from that registry, retrospective registry, is that you can do a safe and successful implant using either 3-cusp coplanar or right-left cusp overlap view. You can do both. The only thing which Mohamed indeed mentioned, the only thing you kind of miss from information if you do the implant purely in a right-left cusp overlap view is that you don't see always, in many cases you still do with experience, but how much push you have on the system. Because in an REO view, you actually, the aortic arch is in a way closed. Yes, the ascending and descending aorta are sometimes superposed on top of each other. If you go to an LEO view, you open up the aortic arch nicely. So that means you see nicely the curvature of the aortic arch. And because it's very important for this device to know how much push forward you have on the system, it helps for sure in the initial phase of your learning curve to assess how much push you have on the system. So that's some information you don't have on the right-left cusp overlap view. But to be honest, in my center, I think we do maybe for sure 3/4 of the cases where we stay in the right-left cusp overlap view because we think we have enough information on how much push we have, and we have very successful implants with this device, I would say. But sometimes if we doubt about how much push we have on the device, we can still go, like Mohamed also demonstrated, you can easily take your time, go to a 3-cusp coplanar view, assess your push, and deploy. So there's never any stress moment, and you can, sometimes it's good to use both incidences, like Mohamed actually very nicely showed here, I think.
So Mohamed, I see you are back. So before you start the case, let us know your practice today. How much you are doing structural and coronaries? What percentage of your practice?
Yeah, good question. I would say probably 65% structure and 35 to 40 coronary.
Okay.
Yes, I would say it's probably like that. It differs a little bit depending like on the, whether you have a lot of on-calls that you have to do, then coronary would be a little bit more for a certain while. But if you take it overall, then it's probably 60-40. Correct?
No.
No.
You do 90 structural.
90-10 said the
95 and 5% you do. I don't know what you do.
I wish I could do that too.